Here's the definition of placenta previa. Placenta previa is a maternal condition marked by the abnormal placement of the placenta in the uterus, where it partially or fully covers the cervix opening. This situation poses substantial risk during pregnancy and delivery, including heightened chances of severe bleeding, particularly during labor. Placenta previa heightens the potential for complications like hemorrhage, premature birth, and fetal distress. Management typically involves vigilant monitoring throughout pregnancy, potentially culminating in a cesarean section delivery depending on the condition's severity. Timely identification and appropriate medical care are essential to ensure the well-being of both the mother and the infant during childbirth. Here are some of the clinical manifestations of placenta previa. The first one is vaginal bleeding. One of the hallmark symptoms of placenta previa is painless vaginal bleeding, typically occurring in the later stages of pregnancy. This bleeding can be sudden and profuse or intermittent and mild. It happens due to abnormal placement of the placenta over or near the cervical opening, causes it to tear and bleed as the cervix begins to dilate during labor. The next one is abdominal pain or cramping. Some women with placenta previa may experience mild to severe abdominal pain or cramping, especially if the bleeding is significant. This pain can be localized to the lower abdomen or may radiate to the lower back. It can indicate uterine irritation or contractions triggered by the presence of blood in the uterine cavity. The next one is preterm labor. Placenta previa can increase the risk of preterm labor due to uterine irritation caused by the placenta location and associated bleeding. Women with placenta previa may experience contractions that can lead to preterm delivery, posing risk to both the mother and the baby. The next one is fetal distress. In cases of severe placenta previa, the fetus may experience distress due to compromised blood flow and oxygenation. This can manifest as changes in fetal heart rate patterns detected during prenatal monitoring. Fetal distress requires prompt medical intervention to ensure the well-being of the baby. And the next one is pelvic pressure. As the pregnancy progresses, women with placenta previa may experience increased pelvic pressure or a sensation of heaviness in the pelvic region. This can result from the downward pressure exerted by growing uterus and placenta, especially if the placenta is low-lying or covering a significant portion of the cervix. And lastly, complications during delivery. Placenta previa poses risk during delivery as the placenta may obstruct the birth canal or detach prematurely, leading to hemorrhage. Cesarean section is often necessary to prevent life-threatening bleeding for both the mother and the baby. The mode of delivery depends on various factors, including the severity of the previa and the stability of the mother and the fetus.
The signs of placenta previa include vaginal hemorrhage, fetal discomfort, abdominal pain or uterine soreness, a soft and non-tender uterus, and the lack of engagement of the presenting section of the uterus. One important sign is vaginal bleeding, which is typically painless and bright red in color. It is brought on by the placenta covering in the internal os of the cervix entirely or partially. While it may or may not be associated with bleeding, abdominal pain or uterine soreness may indicate the problems such as placenta abruption. Unusual heart rate patterns signify fetal discomfort, which is caused by inadequate placental oxygenation. The uterus is soft and non-tender to the touch, and vaginal examination may not reveal the presenting portion of the fetus. In order to direct treatment and maximize result for the mother and fetus, the diagnosis is verified by transvaginal and transabdominal ultrasonography. Supplementary evaluations such as physical examinations, fetal monitoring, and laboratory testing are also performed. A history of vaginal bleeding necessitates additional assessment.
Medical management. If placenta previa is diagnosed during a routine exam, the patient have more frequent ultrasound exams to monitor any changes in the placenta. Repeat follow-up ultrasounds to assure that the cervix is no longer blocked. If the placenta is no longer covering the cervical opening, patient can undergo a vaginal delivery. Women who are diagnosed with placenta previa early in their pregnancies will be scheduled for a C-section delivery. If the placenta covers all or part of the cervix, a vaginal delivery can cause severe bleeding. The physician may recommend no sexual intercourse, tampons, or douching. Severe bleeding sometimes occur with the conditions, which can put both mom and baby at risk of dying. That's why your doctor likely will prescribe bed rest or reducing your activities and pelvic rest. Intravenous therapy. This would be prescribed by the physician to replace the blood that was lost during bleeding. Lastly, avoid vaginal examinations. This may initiate hemorrhage that is fatal for both the mother and the baby.
Women with placenta previa who experience heavy bleeding may require blood transfusion and intravenous fluids. In some cases, tocolytic drugs medication that slow down or inhibit labor, such as tocolytics. Tocolytics agents prevent preterm labor or contractions. Some specialists advocate tocolytics to promote the time for expectant. Management of symptomatic placenta previa. They should only be used after consultation with an obstetrician. Magnesium sulfate. Magnesium sulfate is nutritional supplement and hyperalimentation. It is a cofactor enzyme system involved in a neurochemical transmission and muscular instability. Corticosteroids. Steroids may be administered after consultation with a gynecologist. If vaginal bleeding is mild and intermittent, if the patient is not labor, and if the gestation is less than 37 weeks. Desamethasone acetate. Desamethasone may be given to promote to develop of the lungs in the fetus. Betamethasone helps to promote fetal lung maturity. Adrenergic agents. These agents have symptomatic vasopressor activity. Terbutaline. Terbutaline acts directly on beta-2 receptors to relax urine contractions. Nursing management. So first, we need to ensure the physiological well-being of the client and fetus. So we need to take and record vital signs, assess bleeding, and maintain a perineal pad count. Rate perineal pads before and after use to estimate blood loss, and then monitor urine output every hour. Observe Persia, which is characterized by a rapid pulse, color, cold moist skin, and a drop in blood pressure. Next is monitor the fetal heart rate and enforce strict bed rest to minimize risk to the fetus. So second is inspect the perineum. Clyhauer-Betke test or the test procedure is to detect whether the blood is of fetal or maternal. So third is determine the placental location through ultrasound. If previa is under 30%, it's possible for the fetus to be born. If over 30% and the fetus is mature, it's possible for the fetus to be delivered through cesarean. Fourth is we need to assess the hemoglobin, hematocrit, prothrombin time, fibrinogen, and platelet count. Next is betamethasone. This is steroid that hasten lung maturity. It is given to the mother if the fetus is less than 24 weeks. Given 12 to 24 hours before birth. And 12 to 12.5 milligrams intramuscularly. So next is address emotional and psychosocial needs. So we need to offer emotional support to facilitate the grieving process if needed. After birth of the newborn, provide frequent visits with the newborn that mother can be certain of the infant's condition. Provide client and family teaching. So we need to explain the condition and management options to ensure an adequate blood supply to the mother and fetus. Place the mother at bed rest in a side-lying position. Then anticipate the order for a sonogram to localize the placenta. If the condition of mother or fetus deteriorates, a cesarean birth will be required. Then prepare the client for ambulation and discharge maybe within 48 hours of last bleeding episode. Then discuss the need to have transportation to the hospital available at times. Instruct the client to return to the hospital if bleeding recurs and to avoid intercourse until after the birth. Instruct the client on proper hand washing and toileting to prevent infections. And lastly, call healthcare professionals for any sign of bleeding.